So the first part of this video is just to let you know where the respiratory department is located and also where the supplies are located if we need you to go get us something. As you know, we may be the only respiratory therapist in the building. So at that point, if we are in a room, we may ask you to go pick something up for us. Believe it or not, people do not know where the respiratory department is located. So if you're coming down the main hallway through the double doors going towards the ER, you'll go to the first door on your left. It's easily marked with a wreath that says RT on it, all right? Your badge will let you in. When you hit your badge, you do have to wait a second for the door to click so that you can get in. Once you come in our office, our storeroom will be on the left-hand side. So in our storeroom, there's going to be a sign hanging on the door that's going to have a list of pictures for you to know what we're asking for, all right? So if somebody asks you to get the kaleidoscope for them to intubate, there's a picture hanging up there. It's nicely put down here. Grab the kaleidoscope and take it down, okay? If they ask you to get the transport vent, this would be our transport ventilator. It'll just roll on this cart. So our transport ventilator will look like this, but it's just going to roll on this cart. You'll bring it down to us. Again, the pictures are on the wall. If they ask for the Drager vent, it'll be sitting right back here and it'll say that Drager vent on it. There's pictures on the wall for you. If they ask for you to get them a high flow oxygen setup, this is our high flow oxygen setup. You'll just bring this whole thing with you down to the floor. If they ask you for a filter, these are our filters that we're using with our ambus and our mask. The filters are up here. The HMEs are up here. These are our CPAP masks that you may ask to get if you need an ambu. Ambu bags are in this cabinet, along with the PEEP valves that are over here in the edge. So just some simple stuff that if respiratory asks you to go get, you'll know where to find it. And from there, we'll go on with the educational video. Thanks.
Hi, my name is Kenny Bogert. I'm a paramedic here at Sullivan County Community Hospital. And if we have a possible COVID patient that comes in, first we come to this room here, which is room 8. We put on our PPEs, we don on. We have shields, we have goggles, we have hairnets, we have all the appropriate gloves, and we have oxygen supplies. We have our COVID kit, 1 IV set for patients, and then we also have a COVID set, 2 IVs for the more critical patients. And we also have gowns and biohazard bags that we put their blood and samples in to take to the lab. This is our crash cart, which we would leave outside the room if the patient would have to code. This is our EKG, which we leave it outside the room, come on into the room 7 here, which is a negative pressure room. Once the patient's inside here, we close the door, we leave it negative pressure, put them on a monitor here, take their blood pressure, O2 saturations, do an EKG on them. Then we come over here, we get their temperature, we do an EKG, and this is a COVID kit. Put them on the cardiac monitor, have the patient here, we do all the necessary treatment for this patient. This is our COVID kit, and inside it we can collect the urine sample, we can do all the appropriate swabs, we can get the appropriate blood work with blood cultures, start the IV. Then we also have an extra cardiac monitor that we could use in case the patient would go into cardiac arrest.
Okay, so I'm actually playing the ambulance person bringing Lisa in, and I'm going to stop here at the door, and either the respiratory therapist or a nurse will be coming to greet them at the door if they're possible COVID positive.
Put a mask on you.
So we always want to make sure that they have a mask over whatever they're wearing, or we want to make sure if they're being intubated that we have a filter in line when they're on a ambu mask or a vent. Okay? And then we're going to take her on down to room 7.
So once the patient gets into room 7, it is a negative pressure room, so it's really important that we transport the patient from the ambulance call onto the bed and get the door closed as soon as possible to maintain that negative pressure flow in this room. We also need to make sure prior to coming in here that we are completely garbed up with all of our PPE appropriate to this patient. We also brought in with us is our COVID kit that we make up, which contains all of our supplies that we would potentially need for this patient at this time. Once our patient gets in here, we'll go ahead and hook her up to our high flow oxygen, get her on the heart monitor, do her pulse ox and her blood pressure. At this time, we might do an EKG, and at this time, the EKG machine would remain outside the room, and then the leads within the room, and we can transmit that through the door, with the door being closed. Also, since this patient is potentially critical, we will have this crash cart on standby outside of the room. At no time should the crash cart be brought completely into the room. It should remain outside with a nurse outside the door doing documentation and drawing up our meds and handing them in. At this time, our respiratory therapist is in the room, the doctor is in the room, and then the patient's nurse is in the room. The RT is now going to assess your patient.
All right. Oxygen is 80% on a non-rebreather. We're going to do a blood gas and put her on high flow, if that's okay with the doctor.
Yes.
Do you need to open one of these up?
You can. We just use a small. And realize that if this was our COVID patient, when we talk about proper gear, we would have our shoe covers on and everybody would have their head covers on. We're trying to save on supplies.
All right, honey, this is going to be some high flow oxygen. It's going to help you breathe a little easier.
And just as a reminder, you should be wearing our N95 during any aerosolizing type procedure. And these include, but are not limited to, high flow oxygen, suctioning the patient, inserting the NG or OG tube, intubation, or nebulizer treatments.
Or CPAP or BiPAP.
Mask back.
And mask will be placed back over the patient. The mask will not only help protect the patient, us from the patient, but it will also help with the oxygen high flow.
At this time, Dr. Matt has ordered all of the appropriate tests and screenings. We have done a complete workup with this patient, and Dr. Matt has consulted with this family, with this patient's family provider, which is Dr. Ellis, and he accepts this patient for admission at Sullivan County Community Hospital on the COVID unit. At this time, the patient's going to be admitted as an inpatient. It is very important for us to get the contact information for this patient, so we can update the family as the status of this patient changes. Right now, I'll go ahead and have my ER staff update the family that this patient is getting admitted. I will also take this contact information to the floor so the floor can follow up with the patient's family as well. For the transport from the ER to the COVID unit, we are advised to go down the back hall, cutting through the old ICU and into the COVID unit. It is important to make sure you have enough people geared up and ready for transport and available to help you open doors. At this time, we will be putting a plastic sheet over the patient for protection of the patient and for us, and to slow any aerosolizing particles from being transmitted through the air down the hallway.
At this point, when we transport to the floor, we would want to pre-oxygenate, since this cannot transport by itself without oxygen. We're going to put her on a nasal cannula and a non-rebreather, and then put the mask back over the mask, or this mask back over this mask.
So at this point, we'll just take this patient down the back hallway with just as minimal amount of people as we can take who know about this patient, which would normally be your respiratory therapist and your nurse. Show going out that door now. So after going out these doors, then we would go around to our COVID unit. So at this point, when we bring that patient around to go in this room, either we would want the nurse to check prior to us getting here, or we would want to check to make sure that our negative pressure is set correctly on these patients before we enter that room. And as you can see, it needs to be greater than 0.01. That makes sure that our negative pressure is set up correctly.
At this time, we brought the patient from the ER to the inpatient COVID unit. We are going to transport this patient from the ER bed to the inpatient bed as quickly as possible, getting the ER bed out of the room and the door closed as soon as possible so the room remains in negative pressure. At this time, I will go ahead and give report on this patient to the inpatient COVID unit nurse.
So at this time, it's been approximately 2 hours. Our nurse had came in the room. She realized that the patient sat on a 100% high flow, was registering at about 80%. So she has contacted Dee Dee from respiratory, and she has now called Dr. Ellis. Dr. Ellis has requested that this patient be intubated, and he is en route over to our facility to help us with that scenario. At this point in time, the nurse will be telling the patient what we are going to do. She will ask the nurse outside to contact the family and let them know what is going on. The people in this room will be going out to make sure they have on all their proper attire to intubate this patient. We will call pharmacy. If they're in-house, they will come down and help us with our medication. We will have a nurse outside the room who is appropriately attired in case she is needed. She will not enter the room at this point for intubation. We will have a nurse, an RT, and the ER doctor, or the Dr. Ellis. If we do not have a Dr. Ellis in-house at that moment, we will have a second nurse in the room. If possible, we will have a second RT outside the room, and we will have a second nurse outside the room in case we need to start compressions on this patient. So everybody will now be leaving to get donned and our proper attire.
All right, who can tell me what's going on?
COVID unit, this is Janice.
We got this patient up from the ER. Saturations are dropping, increased work of breathing, and he's become non-responsive.
Okay, I think we need to go ahead and prepare for intubation. So pharmacy's outside the door. I'd like to prepare ketamine, fentanyl, and rocuronium for rapid sequence intubation.
Can you hear that okay?
Yep. Ketamine,
Patient.
fentanyl, and rocuronium.
Patient weighs 100 kilos.
Nice. From the dosing cards in the RSI box, and the RSI box, the paralytic box, is stored in the refrigerator. The sedation box is in the Pyxis, and the fentanyl comes from the Pyxis. So using the dosing cards, we'll calculate the dose for this patient at 100 kilos. I got it. So the ketamine dose is 1.5 milligrams per kilo, so we would give him 150 milligrams of ketamine. The fentanyl dose is 1 milligram per kilo, but we'll round that off and just give him 100 micrograms, it's 1 mic per kilo, so we give him 100 mics of fentanyl. And then the rock, we would give 1.2 milligrams per kilo. And on the dosing card for rocuronium, at 100 kilos, it works out to be 120 milligrams. Okay, one of the enhancements we've made into Meditech, if we know a patient is coming and needing to be intubated, we can print an emergency drug sheet it has the patient's weight on here, and it calculates the doses for the nursing staff. We can make 2 copies of this and make sure pharmacy and nursing has a copy of this sheet so everybody knows the doses that we're going to be using for all these medications. Okay, so now I'm going to show Judy the fact that we're giving 1.5 milligrams per kilo of ketamine, and I'll hand that to her. She verifies the dose. Then also the fentanyl, and I would have an ampule of fentanyl here to show her that that's what I've drawn up.
Okay.
And then last but not least, the paralytic, I would draw it up and show her again, as my double check, this is the dose of rock for the paralytic. And we will have these labeled for her so when she hands them off for the nurse, they know what she's getting.
Okay. And then now I'm opening the door to the negative pressure room, giving them to Jana, and they're labeled. And then I'm going to shut the door to the negative pressure room.
So, Jana, we want to give the ketamine first. After we give the ketamine and the patient's dissociated, I'd like to try some CPAP to pre-oxygenate this patient. So go ahead and push the ketamine.
All right, I'm giving the ketamine. Ketamine documented. And flushing. Ketamine is in.
Great.
Be advised that we have made a phone call out to the hallway, and our nurse documenting does have a phone line open to the room. So our nurse will be documenting everything for the people in the room.
We're going to give our fentanyl next. Our SATs are starting to respond to the positive pressure.
All right, I've got 1213 pushing fentanyl.
Great.
You'll note that Dee Dee has a CPAP mask hooked to our ventilator right now. It would be strapped down and tight with a filter in line so that that is not coming back out into the air. We would have strapped those around the patient's head so that we had a tight seal. Prior to starting intubation, then they will pause that ventilator so that it does not blow out into the room, and then have it set up ready to go on to the ET tube as soon as she finishes intubating. And then we will also directly hook up the end-tidal CO2 to be able to check the end-tidal CO2 for breath sounds.
All right. Now we'll give the rocuronium.
Flushing.
Rocuronium's flushing. Can the writer please go ahead and start a 60-second timer? Let us know when it's been 60 seconds after it's given.
Okay. Rock is in. Flushing.
Simulated time, 60 seconds.
Okay. So we're ready to intubate. Turn off the CPAP, please.
Already done.
Great.
Patient at minor for you? Okay.
Okay, at this point, Dee Dee's going to use our glidoscope to intubate this patient as quickly as possible. As soon as she has intubated, she's going to remove that. She's going to immediately hook up to our ventilator. She's going to then hook up our end-tidal CO2. And then somebody, either Dr. Ellis or the nurse, is going to go ahead and listen for breath sounds. We are going to, at all costs, try not to ambu a patient. We're going to look at our vitals, make sure our oxygen saturation is coming up. So if somebody wants to check that for us.
Sounds. Breath sounds bilaterally and good chest rise.
Sides are coming up.
End-tidal CO2
35.
is 35. So our nurse outside will be documenting all of our vitals. At this point, we'll be securing our tube. And at this time, Dr. Ellis, you would like a Versed drip and a rock drip, I'm
Yes.
assuming, for this patient?
Yes, please.
Okay? And
Pharmacy starts.
our pharmacy is going to get that ready for us, so we'll have that set up and ready. Please note that we still kept this clear sheet on our patient throughout this, and we're working over and around it, okay? Now we're going to go on through our simulation. We're going to assume that as we're getting everything ready, Dr. Ellis, do you see a heart rate?
So, patient looks like it's in asystole. So we need to call a code, get some help. We need somebody to come do start chest compressions.
No heart rate.
No heart rate. Okay, let's start compressions.
So at this point, we're going to have somebody doing compressions. We're going to pull our bag up. Dee Dee is going to turn off the ventilator or put it on standby. So, and she is going to connect the ambu bag and have that with the filter underneath of the plastic.
Need to draw up a milligram of epinephrine.
Drawing up 1 milligram of epi.
Go ahead and administer it as soon as it's ready.
1217, epi 1 milligram given. Flush.
Epi given, 1 milligram, 1217.
So at this point, we would do our CPR for our 2-minute cycle before we recheck for a pulse. So let's say it's been 2 minutes.
Yeah, let's see where we're at here. It looks like there's something on the monitor. You want to pulse with that, Janet?
Yes.
Okay. Let's cycle patient's blood pressure here and see where we're at. Reconnect to the ventilator. Now we have an organized rhythm.
And we do want to advise people that if you have a patient on the COVID unit and you happen to be the nurse that walks in the room and you realize that this patient has no pulse, you will begin chest compressions only. You will call the code and you will do chest compressions while your team acquires the correct apparel to put on prior to entering. We will not ambu this patient. We will just do chest compressions until everybody can enter correctly. All right, so just a couple extra things. If this patient was staying here on the ventilator with us and not being transferred out, then Dr. Ellis is going to want a central line. Correct, Dr. Ellis?
Yes.
Central line and an art line put in. If that was the case, then we would do this right after the patient was intubated, and we would get that done prior to everybody leaving the room. If this patient is going to be transferred out, then we will not be putting those in. If this patient is being transferred out on the ventilator, then this ventilator will stay with this patient and go out the door with this patient. At no time are we going to be disconnecting this vent from this patient to ambu him out the door. So we have done this twice with the ambulance crew already. We will be sending them a green tank, and they will transfer completely back up to the room at Regional or Union, wherever they're going, and they will stay on this ventilator. They will be on that COVID unit, so they will be going out the back door and being put on the ambulance out the back door by room 110. And just a little bit of information for you all, if you've seen us do this, if you do have to ambu a patient for some reason, on your crash cart is going to be your filter, your CPAP mask, and your ambu. All right? So you can put this filter in line, hook this to your CPAP mask, strap this on your patient's face. You do not have to keep a C-clamp on the patient's face at that point to ambu. You can get a nice, good, tight seal and ambu. Please make sure when you're ambuing that the exhalation port is turned away from your face. All right, even though the filter is going to help you turn the exhalation port away, and then you can ambu this way. I have this on the crash carts in the ER, I have this on the crash carts out on Med-Surg, and I have this on the crash cart down in the RT clinic, just in case they have a patient that collapses down there. And we hope this video helped all of you all. If you see anything we did wrong, we'll take critiquing, because that means you've watched our video.